Hi, this is Muhammad Atman, and this video will show a bone for type 3 achalasia. And type 3 achalasia is a spastic achalasia. A spastic achalasia means that you have multiple segments of contraction in the esophagus, as you can see here. And in this particular patient, it was very hard to pass the scope during these contractions. So this is unedited version of the procedure, and you will notice that I have the time up there in the upper right corner. And the intent of this video is for people to watch the entire procedure. It's for gastroenterologists who are already performing bone procedure and would like to look at the small details, such as how to widen your tunnel, how can you adjust your knife and prevent spiraling. You will find few tips about that. I will not be talking the entire video. I will just be highlighting certain areas. But I just would like to say that in type 3 achalasia, we tailor the incision and the myotomy based on the length of the spastic segment, and we obtain that from our motility report. And you can also see that in the contraction of the esophagus in this case. As you can see here, we have determined the location of the initial incision so far up in the upper esophagus. It's very important when we do the initial incisions that we do not inject too much. Some people get so excited about injection, and if you notice, if you inject too much, the fluid will start to go all around, and then when you do your initial incision, immediately there will be a depression, and then it will be harder to complete the incision. So maybe 1 to 2 cc of injection, then after that you can utilize your knife, and once you are in the submucosa, made your initial cut, you can put more liquid. As you can see here, we just got into the submucosa, injected more, and then now we're going to use the knife, and we're going to do a longitudinal incision exposing the submucosa, and then using the coagulation grasper, I am going to start to coagulate all the submucosal fiber to allow us to enter into the tunnel. So the secret of entering the tunnel is to remove the dense submucosal fiber which prevent us from entering there, and you can see here there is still small amount of fiber on the left side. You don't have to use cut current here so that you don't cut the muscle layer under it. You just use simple coagulation to allow you to enter. You can notice that although I'm almost getting into the tunnel, there's still submucosal fiber preventing us. Try to widen the tunnel a little bit, but you notice that still not there yet. Why? Because there's a small submucosal fiber on the right side now, which are preventing us from entering. The more we cut them, now we enter the tunnel right away. So it is simply making initial incision and then coagulation of all the submucosal fiber on the right and left side of the incision, which will allow you to enter into the tunnel. So something we should remember when we are creating the tunnel, especially in the initial part, is to have a wide tunnel. Why wide tunnel is important? Because wide tunnel is what will allow you, when you reach to the GE junction, to be able not to spiral and to be able to bypass the tight segment. So always focus on widening your tunnel. So that's one of the things that people who does POEM initially, they don't focus on, which they do very tight, small tunnel, and they start spiraling right or left. If you widen your tunnel, as you can see here, you go up, look from far away, and dissect the fiber in both right and left side. This will allow you to be going in a straight direction. You can see here I'm having the knife extended out, but I'm also trying carefully to dissect very close um, to the muscle layer, and it is okay even if you burn a little bit of the muscle layer. This will give us a landmark that we are in the muscle. But you dissect from close, you go far away, you see where you need to dissect more, and you work on widening your tunnel in both direction, right and the left, and also make sure that you don't focus on one side, forgetting the other, because that's how you end up spiraling. So right now, we focus a little bit on the lower side here. We discover that we need to dissect a little bit more in the upper side. So it's just a continuous process of dissecting right and left, widening your tunnel. You get closer, dissect closer, then you go far away and come back and dissect, and that will show you how to have an efficient but successful tunnel. So as you can see here, the longer the tunnel, it gets confusing sometimes. The mucosa start to tilt, and especially in achalasia cases, if you have sigmoid esophagus, the mucosa can play tricks on you. So what you do, you just follow the muscle layer. So when you dissect, you come back, see where is the muscle layer, see where is your midline, and follow exactly straight line from the muscle layer and ignore the mucosa. If you follow the mucosa, you will spiral. If you always look at your muscle layer and use it as your reference, the muscularis propria will always lead you to the right way. So here, looking back, we discovered that we just have to dissect the muscle a little bit away from the mucosa, and now still our tunnel will continue to be straight in spite of having the mucosa curving like that. And you'll come back right now, confirm that you're in the right direction, and continue your dissection away from the mucosa, as you can see here. So now the tunnel is getting longer. It's always, every once in a while, good to come outside the tunnel and see your progress from outside. So here's our incision. You can see that it is clear. We'll follow the incision all the way down, or going straight, almost reaching the GE junction. We're not there yet, so we can tell right now that we're still maybe 4 to 5 centimeters from the GE junction, but we are sure that in this very long tunnel for type 3 achalasia, we're going in the right direction. Maybe there's a slight spiraling in this long tunnel to the left side, and I noticed that, and that's why we are correcting it right now by dissecting the submucosa to maintain uh, the tunnel in one direction and to avoid spiraling. The closer we get to the GE junction, it's still important to maintain this white tunnel. So you come back, identify where the tunnel is narrowing, and keep dissecting. We tend to create a narrow tunnel at the GE junction, and that's natural, and the reason is the space getting tighter. So in this situation, you go up like that, identify where is the area where you did not widen the tunnel, and you dissect it, and then you inject a little bit lower and keep dissecting um, till you reach the GE junction with the tunnel as wide as you started. Okay, in this part it seems like as if I'm hitting the mucosa. Well, this is a junction of the mucosa of the muscle layer, and I'm injecting first, and then I am trying to dissect as close to the muscle as I can. So if you can see here, although it appears that it is going blindly and I'm cutting into the mucosa, I'm not getting closer to the mucosa. I'm very close to the muscle layer, but also if you do 100 of palm, you have this muscle memory. Your hand know exactly where you dissect, so it appears to you in the video that I'm cutting into the mucosa, but as you can see here, the mucosa is intact and our focus is toward the muscle layer. You can tell right now we are by the GE junction. It's getting very tight, so I'm using the cap to widen the tunnel. The blood vessels is getting wider, and you have to be slower. So you can see my base now is slowing down, because that's when you start making mistakes. That's when you can tunnel into the muscle layer, and you can see a little bit of this start to happen here, that when I'm dissecting, it is going to the muscle layer. So I determine now that I'm at the GE junction. So now I'm going down to look, see how deep we are, and yes, we are at the GE junction now, just there. We still maybe have another 1 centimeter or 2 centimeter to go to, but we confirmed our location at the GE junction. So in this segment, as you can see, we first injected and now we are dissecting the fibrotic GE junction. And with fibrosis will come this blood vessel that you have to be careful when you are dissecting them. And we are beyond the GE junction now, maybe 1 centimeter, so we can continue our dissection slightly deeper. And you don't want to go so far, like it's 2 centimeter beyond the GE junction is enough. More than that, you may increase the risk of reflux or bad reflux. You can tell that the tunnel widened. And we are going to confirm by going outside the tunnel right now exactly how deep the tunnel is. So 17 minutes into the procedure, we are starting our long myotomy. As you can see here, we are so far up in the esophagus. Same principle, like any myotomy you are doing for POEM, is that first you want to identify the line between the circular and longitudinal muscle, and then you can decide whether you want to do only circular myotomy or go all the way for full thickness myotomy. So the closer we get to the GE junction, the thicker the muscle layer will be. You can see here the circular muscle is getting more thicker, so our myotomy would be slightly harder because you have to cut through a larger portion of the muscle. And you can see here that we're getting closer to the end, and you can see how the muscle is spastic even up there. But once you identify your longitudinal muscle, that dissection would be easier. So we're trying to go full thickness. The closer you get to the junction 2, it is better to do a full thickness to obtain good results, especially at the GE junction level. You better do it full thickness because that's the part that's very tight and very hard to dissect. And immediately after the GE junction, you will notice that the muscle, circular muscle layer, become very thin again. And you know right now that you are in the gastric side, and you extend your myotomy for 1 to 2 centimeter beyond the GE junction, and that is enough. No need to continue going forever at the stomach side. It's a good habit to inspect your myotomy and then try to dissect this extra fiber that you think that they are not dissected yet, which allows you to have a complete myotomy. So inspect carefully and go to the GE junction, see how it feels. Is it easier to advance your endoscope or not, to make sure that everything is good. So closing the incision is an art, and as you can see here, we're using the clip. It's very important to have your clip exactly at the incision line to allow equal force on the right and left side of the incision line, which will result in equal closure, and it will make it much easier to deploy the next clip. So this procedure, starting from incision till complete myotomy and incision closure in less than 30 minutes. And also we created a very long tunnel, around 20 centimeter tunnel, as you can see here. Thank you for watching.